So, latent tuberculosis. Please hands up those who don't know what latent TB is, so that we can sort of start off. Hands up those who don't know. Okay, everybody knows what latent TB is. Okay, then I give you a chance to say what latent TB is.
But there is no disease.
Very good. So let's go very close. So let's try to come up with a very day-to-day example. So just imagine I'm out of medicine. Just imagine that the CID is looking for me, and I'm hiding in your house. Okay? I'm hiding inside your house, and you know that I'm there. I'm not doing any harm to you. Okay. Now the CID wants to find me. You want to diagnose later. Okay. So what do? You put out an announcement. This is what I look like, and all that. Then you test. But I don't take any mobile calls. I don't use the internet. I'm just they are without doing anything, just eating and just surviving, not communicating with outside. So the CID is not able to find it. Okay. So now what the CID does is make somebody look exactly like me and each of you. Right? The one who is hiding me will react. You know, they will react. Oh, why are you outside? Go and hide. So that is what we do to diagnose latent TB in a very simple way. Okay. Latent tuberculosis is the persistent immune response to stimulation by Mycobacterium tuberculosis antigens with no evidence of clinically manifest active TB. So that is the most important thing. If we can get the pointer to work. Point options. This one. Done. Okay. That's fine. So it is, in other words, to make it simpler, infection without disease. So if we don't treat latent TB, 10% of those will go on to develop active TB during their lifetimes. And 5% will happen in the first 2 years after infection. That is the most risk period. So this fact is very important. First 2 years, 5% will develop active TB. And after that, it's about 0.1% every year. Now, not everybody infected with TB bacteria will develop the illness. In latent TB infection, an immune response is triggered within the body. And this immune response doesn't happen immediately. It happens within 2 to 8 weeks after the exposure. So that statement is very important, because if you test a person within the 2 to 8 week period, they may be negative, and doesn't mean that you have excluded latent TB. In these people, the TB bacteria are killed, contained, or encapsulated. Now, if you look at this in detail, TB is a part of a spectrum of disease. So you can have oops. It's either the pointer or the zoom. Sorry. So can you see this picture? No? Okay. So then let's zoom in. Okay. Better. Let's use this. Oh. Try again. Zoom in. Let's do it differently. This one? Okay. Okay. So at the lower part, this is when we get the, exposed, sometimes especially if the load of exposure is low, our innate immune system can deal with that TB and kill it. And if that happens, you don't, go on to develop any immunity to T cell priming. So those who are properly tested for latent TB without any reason for any false negative results, if their immune system, gets rid of the TB before it's exposed to the T cell priming, they will not get latent TB. Clear? No. Anyway, so if the innate immunity is unable to deal with the TB, then the T cells will be presented with parts of TB, and they will get primed, and our immune system will get programmed to deal with this TB, and that takes some time. During this time, the TB is slowly replicating, and then we go on to this is the stage where they are slowly replicating. So they are sometimes showing some clinical features like, they are ill, they are having, appetite is lost. Sometimes they will go on to lose a bit of weight. But if we really test them, do some imaging and test the organs involved, we don't really get any features of organ involvement. So there is no active infection. Active infection is when you get the organs involved. For example, if it is pulmonary TB, you will get features in your chest X-ray, or more importantly, more sensitive is the CT scan. So then the disease is when you get the active organ involvement, and during that time, the bacterial load is much higher than when we began, because they have replicated. And also when you have HIV, the risk of developing active disease is more. And therefore, like HIV, there is a subpopulation within the group currently defined as having latent TB who should be preferentially targeted for preventative therapy. So not all people with latent TB need to be treated. It is a special population out of those latent TB people who need to be treated. And also, the treatment that we have existing is not the ideal treatment. So we are currently in the searching a way to shorten the duration of treatment and also to make it more effective. Now, the most important message is that active TB should be excluded before treating for latent TB infection at all times. So how do you exclude active TB? Look for symptoms. Okay, before you think about the gene expert, please look for the symptoms. Take a history. Examine the patient. If they're having these 4 things: current cough, weight loss, night sweats, fever. Say current cough, weight loss, night sweats, fever. Okay. Suspect active TB. Okay. In addition to that, with regard to infective TB, or in other words, pulmonary TB, there are chest X-ray is a very good way of diagnosing whether the patient is having pulmonary TB as well. I think we will deal more with that in the later lectures. Now, how do you confirm latent TB infection? It is either with a tuberculin skin test or a positive interferon gamma release assay. Because we don't have the interferon gamma release assays with us in a free manner, I'm not going to talk much about it, but I will talk a bit more about the tuberculin skin test. The MAN2 test is the test that we have. Now, when you get a MAN2 test positive, you all get excited and we all get referred, and thank you for that. But there can be reasons other than latent TB which cause a false positive MAN2 reaction. One of those is an infection with a non-tuberculous mycobacteria. So there are more than 200 species of non-tuberculous mycobacteria, some of which cause disease, some of which don't cause disease, which can give rise to a false positive MAN2 reaction. The other one is the previous BCG vaccination. Now, now the recommendations are different for these recommendations. Some of them have been made for Western countries. Now, they vaccinate their people at a late age, but our vaccination happens soon after birth. So you have to interpret the recommendations with a bit of brain. So the effect of BCG vaccination in Sri Lanka, Dr. Uragada has found that it vanishes by at about 11 years of age. So up to 11 years, the MAN2 may be positive due to the BCG vaccine. The other one is incorrect method of administration. So the way you administer is very important. So that's why it should not be done outside of trained settings. And the other one is incorrect interpretation of reaction. So with regard to that, some people do not interpret, they interpret the redness as positive rather than the induration, which is the proper way of measuring. Now, the other important thing is when you see the MAN2 result, it doesn't matter whether it's positive or negative. What matters is the size in millimeters. So remember, if you see a positive or negative, it may be not applicable to the patient you are dealing with. But if you get a size or in millimeters, you can interpret it more. For different people, different sizes are applied. So what are the reasons for a false negative MAN2 test? So if your immune system is weak, you will not react. If you do the like we do the screening, you do it very soon, they will also be negative. So when you do the contact screening, you should not do the MAN2 test very soon after. You have to wait until at least about 1.5 months. So in elderly people, in the very young age, when their immune systems are not very, up to standards, it can also be false negative. Or else, when our immunity is engaged with other diseases like measles, chickenpox, and other viral infections, where the T cells are otherwise engaged, the BCG, the MAN2 test may be negative. And also, like the similar way, if you do it incorrectly, it may be negative as well. And also, if you don't know how to interpret it properly, it will again be negative. And also, for some reason, most of the MAN2 tests that happen in Nuerelia are negative. I don't know why. Now, again, I come back to that. Neither the MAN2 test or any drug test can be used to diagnose active TB disease. So please don't diagnose active TB disease based on a MAN2 result. And now, in whom should we do this screening for latent TB? I think this is a very little addressed area that I think we should focus on. Now, all of us have undergone government medical, no? Okay, hands up who had a MAN2 test out of that during your government medical. No hands up. No. So if you take the government medical and read that, MAN2 test is there. It is absolutely essential. Why do you have to test for latent TB before you actually enroll into government service? It's to see whether you have active TB. Now, if you don't have it, if you're MAN2 negative enrollment, that means after your first exposure, the next 2 years that we have to look out after you. So having that important piece of information I think is very good. And also to have that result. And in those tests, you can do a boosted MANTU test. And that is the recommendation. So anyway, there are guidelines for testing for latent TB and also for occupational screening for TB in our medical, profession and in our healthcare staff. Now that is not happening. We are focusing on a whole other group of people. That is good. But I think this also needs to be focused, and it is probably likely to be more resource efficient process. Now, who are the other groups that we have to screen for latent TB? Now, this we are doing universally. We are testing people living with HIV. And also, we are testing HIV negative close contacts of a patient with pulmonary TB. Those are the infective TB patients. And also, even without exposure, we are testing the other at-risk groups. With regard to people living with HIV, all of them need to be, including the pregnant women, need to be screened for latent TB after excluding active TB. And also it says, even if you complete treatment for active TB, you have to be on the lookout for reactivation in these people with living with HIV. So again, we come to the cardinal rule: always rule out active TB first of all. So in HIV, people living with HIV, the recommendation is to do both tuberculosis, tuberculin skin test, that is the MANTU, and IGRA test, because it is more sensitive in people living with HIV. But even if both are negative, if the immunity is very low, the CD count is very low, we have to make a clinical decision on whether to treat with tuberculosis prophylaxis treatment or not. And also, even if they are pregnant, we have to do this. We do test people with all the close contacts with the pulmonary TB, but this is a very exhaustive process. For example, if you take for example, a school child, all the contacts need to be screened. So that is a very resource-intensive process. Now, that is why this treatment of latent TB is only implemented in countries with low TB burden, because then only it is practical. Now, if we do a real calculation about the burden of resources to screen for latent TB in Sri Lanka and economic burden, I'm not sure whether it is actually practicable or economic to do this. If you're doing something, we have to do it properly. And I think this calculation should be the first part in deciding whether we are going to screen for latent TB or not. But the recommendation is, of course, to do screening of close contacts of a person with pulmonary TB. Now, the other important thing that is coming out nowadays is drug-resistant tuberculosis. Now, we have to screen the contacts of people with drug-resistant tuberculosis as well. So, okay, then we screen, then it is positive, then what are we going to do? So that answer is not yet in the guideline, is it? Is it in the guideline? MDR TB, latent TB, how to treat them? Not yet established. So those issues, I think we need to address together as a college and also together with the campaign, how to deal with this. So again, let's move back and maybe the back row can answer. So when do you test a person who is a close contact of a patient with pulmonary TB When do you test them for latent TB? Back row, madam. Yeah. When do you test them? After 8 weeks. Okay. Yeah. And also we test the HIV negative at-risk groups, including patients who are on anti-TNF treatments, those who are receiving dialysis, preparing for solid organ transplant or hematopoietic stem cell transplant, or patients with silicosis. And also prisoners, healthcare workers, immigrants from high burden TB countries, people who are using illicit drugs, may be considered based on local research evidence, individualized risk assessment, and sound clinical judgment by experts. Now, this statement is very important. Scaling up latent TB infections testing for this high-risk group will be carried out based on programmatic factors and assurance of treatment completion. So we have to make sure that our logistics are in place when we are trying to do this. So the question is whether to treat or not to treat these people with latent TB infection. Now, can people living with latent TB infection refuse treatment? What is your answer? I believe they can, because they are not infective to others. They still have the autonomy to refuse treatment. So, and then we have to do a risk assessment about developing active TB. When they developed it, how their immunity is, what are the risks of getting active TB. And also the risk to others, especially in healthcare workers. If they develop TB, all the immunocompromised patients also will get exposed. So therefore, they deserve to be screened for latent TB. And also the risk of developing drug-related side effects. Some people, if they're quite risky of developing or dying due to the treatment, better not to treat, because there is a chance that it may not get activated. And the other important thing is, sometimes we don't treat if we are not sure whether there is active TB. So then it's better to treat for active TB after properly assessing, rather than venturing for treatment of latent TB and getting that patient resistant to the drugs. So there are two regimes to treat latent TB that are currently used in Sri Lanka. One is isoniazid alone regime, and also the other one is isoniazid plus rifampicin regime. And also I believe that we should consider rifampicin only regimes for people with liver problems, which is very common in Sri Lanka. What is the future? I think we need to ensure compliance, and people are researching into depot injections. You can't remove them. So if they develop some hepatotoxicity or something, we are in trouble. So maybe we can do some research into implants which are removable and slowly release the drugs for the duration necessary.